good as sitting in front of each other and enjoy what technology has to give us and enjoy interacting with each other. So the title of my talk today is Clinical Success in PCNL. And I can't, slide doesn't move further. Yeah, it does. And for those of you who have not been into India, this is where I'm sitting at the moment in the city of Ahmedabad, which is western part of India. And we do workshops here. So Uli is here very regularly, twice a year we do these live workshops. We'll discuss about those later. And the objectives of the talk today are that we will discuss how to get the best results from PCNL. We all know that PCNL is the best treatment option to give you the highest stone-free rate. And we now, as we learn more about it, we want to extract the best results with minimum morbidity. So that's what the talk is all about. And that is achieved by two ways, by doing a good puncture. So my intention is today to take you through the steps of how to do a good puncture. In other words, take the fear of puncture out of your mind, because some people who have the fear would use these words, well, after all, it's a puncture. At the end of the talk, I want all of you to feel that after all, it's just a puncture. And the second part of the talk is we will discuss the equipments, because if we want clinical success, good outcomes, we have to use very high quality equipments which will give you the best results. So let me start with these 4 points. So the talk is divided into 4 points: how to select a proper case, skills to do a good puncture, selection of PCNL technique, and appropriate armamentarium. Out of these 4 things that we will discuss today, the most important 2 are the skills to do a good puncture and appropriate armamentarium. So let's start one by one. Case selection. Now we all know, you are all already into this game. Some of you are experts, some of you are fairly senior. So we all know that to select a proper case is very important. Leave the small stones for ESWL, for the small and the relatively mid-size for RIRS, something below 14-15 millimeters. You should withdraw anticoagulants. This is a puncture, so we don't want patient to be on the anticoagulants, because a lot of patients are actually these days, the cardiologists, they put them either on aspirin or they put them on clopidogrel, and it's mandatory to withdraw the anticoagulants at least 5 days before you plan the puncture. Ectopic kidneys is quite a challenge, so it's best to avoid PCNLs in those. Of course we can, but it's a separate topic by itself, so it's best to avoid, do a flexi in ectopic kidney stones. And again, where the anatomy is very, very challenging, extreme scoliosis, kyphosis, again, are challenging cases. So best to avoid those situations. So that brings me to the second part, skills to do a good puncture. Now this is an important part of the talk, and a fair amount of the talk is going to be concentrated on taking you through the steps of producing a good puncture, because that is extremely important. It is the foundation of a good PCNL, and we all know that 75% of the job is done if you have done a good puncture, and vice versa. If the puncture is bad, it's going to harass you all throughout the procedure, nagging, bleeding, the vision is not good, you end up not removing the full stone, post-operatively the nephrostomy is for a long time, sometimes even transfusions, perirenal collections, everything goes wrong if the puncture is not good. So to produce a good puncture, what do we want? We want, first of all, help from the imaging modalities. So it's either a fluoroscopy guided puncture or a sonography guided puncture. very many times a combined approach. So there are people who would do a sonography guided puncture and do the dilation based on fluoroscopy guidance. And there are some people in the world now who do an entirely sonography guided puncture and tract formation. They call it the fluoroscopy free PCNL puncture. This needs a fair amount of experience, and we'll discuss all this by and by. So to do a puncture, again, there are debates, prone and supine, and Guido Giusti is going to engage you after a week on the supine position. All that I can tell you right now is both are good positions. A majority of the world as of now does prone, but supine also has caught up momentum. And there are some pluses and minuses, which puts equal marks, which gives equal marks to both the procedures in different situations. But somebody just a few days back in one of these debates, he summed it up and said that a large part of the world drives left-hand drive and a large part is driving right-hand drive. And as long as you are comfortable with either kind of driving position on the wheels, you are good enough. So that's the take on position. What we should be prepared when you do a fluoroscopy guided puncture, because that's what I normally end up doing. We have sonography in the department, in the operating room, but it's essentially a fluoroscopy guided puncture. So we need a lead apron, which is compulsory to prevent or to protect yourself from radiation. Lead glasses, very important, with a side protection as well, as you can see in this picture. Thyroid shield, which puts a protection on the thyroid and the thymus, so a little bigger one is always better. A radiation badge, which is always clipped here so that it is monitoring how much radiation I'm taking, and which goes every month for a check. If I'm exceeding the safe dose, I'm told to be away for a while. The foot control with the surgeon, that's what is very important with me. There are some operating rooms in the world where they have a radiation technologists, so technicians. A good idea, but then you tell him put it on and put it off, and there is a lag, and there is always a little additional radiation. So it's best to do it yourself. That's the feeling, and that's what we do in Ahmedabad. You should have a sonography unit in the OR to have a scanning of the different organs, keep the organs away from harm's way. And if you are wanting to do a sonography guided puncture, go ahead. That's also a good way to puncture. But at least a scanning before you make sure that the colon is far away or the liver is not on the way on the right side or the spleen on the left side. So that would be helpful. And a 3D image, a CT scan 3D image, which your radiologist colleagues will easily give it to you. So that is very important. You know, it will give you a 3D reconstruction of the cheilices, and beforehand you will know already that these are the posterior cheilices and these are the anterior cheilices. We are interested in going through the posterior cheilices, as you all know. So this 3D imaging is always a good idea, and it's very easy. It's very easy. All the radiology departments will be able to give you that reconstructed images, which will help you understand the anatomy very, very precisely. Now, let's come to the fluoroscopy guided puncture, in which the puncture is done with the use of two planes. And I'll tell you what I mean by these two planes. So plane 1 and plane 2. Plane 1 is the vertical plane, the 90 degrees cut of the X-ray beams, and plane 2 is an oblique cut. And this plane 2 is achieved by two different ways. There are two options of producing plane 2. We'll discuss those things. So, what are the two options? The bullseye technique, in which you move the C-arm towards you, towards the operating urologist, the surgeon, or the triangulation technique, where the C-arm moves towards the foot end of the patient. So let's start with the bullseye technique. Now, this terminology has come from hitting the eye of the bull in those bullfighting rings. The torero hits the spear at the eye of the bull. That's where he is supposed to aim. So here we are aiming the tip of the calyx. So that is how the name is derived. And in which the examination with the C-arm at 90 degrees defines the medial vertical plane. And then the C-arm is rotated about 30 degrees, if possible a little more than 30 degrees, to provide an end-on view of the calyx. When you move towards you, there is an oblique cut of the X-ray beams, and that will provide an end-on view of the calyx. So you need two planes, the vertical plane and the oblique plane. That is bullseye. Let me show you on this diagrammatic images. So this is plane 1, the vertical cut. The patient is in a prone position. The surgeon is standing on the side of the kidney to be operated. The needle is placed on the patient, not yet punctured. So you put the needle, and the whole needle is the whole shaft of the needle is shown by the X-ray beams cutting in the vertical manner, and you know that you are going to hit the tip of the calyx, but you still don't know how much deep you have to go, and that is told by plane 2. You move the C-arm towards you, and that alignment, tip of the calyx and the tip of the needle are aligned, and there you go, and you make the final push. So this is the triangulation technique. Once again, on a diagrammatic sketch with the actual C-arm picture, this is the vertical plane, and this is the oblique plane. This is the 30 degrees tilt. So the vertical plane is where you see the full shaft of the needle here, and the oblique plane you see the tip of the needle, and you align that with the tip of the calyx, that is your desired site of puncture. And when you do that, when you're moving the C-arm towards you, if you hold the needle with your hands, your arm, your fingers come on the way. You know, the X-rays are going to hit your fingers. And if you are a high volume surgeon, every day you are taking the brunt of X-rays on your finger. So a lot of people, they hold the needle with a long forceps. There are different devices made by companies. You know, you can hold the needle with a kind of a ruler which fits onto the needle, and you can move the needle, push the needle up and down with that, so that your fingers are away from the X-ray beams. So there are different things available. It takes away the fine feeling a little bit, and I'll discuss that later on. So this is essentially the bullseye technique, plane 1, plane 2 towards you. I'm repeating this a little more often, 2 or 3 times, so that I'm able to transfer the concept which is in my mind to all the people who are listening. So this is the oblique plane. This is the oblique plane. The needle is in the same direction as the X-rays. This is the tip we are interested in puncturing. We want to make sure that we are coming to the tip as laterally as possible. Don't go straight onto the stone, because there are major vessels parallel to the calyces. There are major vessels parallel to the calyces. That's how the anatomy is. So there are some people who hit the stone directly. In that case, you will hit this main, or main, not the main, but a relatively bigger blood vessel, and that gives rise to bleeding. So it is best to go on the tip from as lateral position as possible. So this is the window from where you can puncture. Don't puncture from here. Don't puncture from here. This is the window from where you have to enter. Okay. And this is the vertical cut. As I said, the needle is fully seen, and you are hitting the desired calyx, and the tip of that needle is already shown by the oblique image. Now, there are some people, they do a freehand puncture. They just use one plane. They just use one plane. They put the needle on the table, on the patient. The patient is prone or supine, whichever way. We do it prone mainly. So the patient is prone, for example, and this is the calyx that I need to puncture. And I put the needle on the patient. If I put it here, it's going in the wrong direction. If I put it here, it's going in a wrong direction. So I put it here and I go directly. Okay. So I put it here. So I know this is how I will puncture. And that is where I would put a small cut on the patient and push the needle. The depth is decided by my experience. I just go in And if it doesn't hit, I come out and become a little superficial. If it doesn't hit, I come out and go a bit deep. So it's a freehand technique where only one plane is used and the second plane goes by your experience. Now, a lot of experienced people do achieve it. I have nothing great to criticize on this, but I feel when you have the C arm, it takes just a couple of minutes to get the plane 2, which gives a lot of precision to your technique. Why not do the plane 2 as well? And I'll tell you what can go wrong sometimes if you use just plane 1. And if this is the needle, on plane 1 you have punctured. So you on the screen you have seen that this is the line of the calyx. You have seen the lie of the calyx and you go in. But on plane 1, just one X-ray, you don't know how much deep it has gone. It could be superficial. It looks it is going in the calyx, but actually it is superficial. Or it is going actually deeper. On plane 1, everything looks like it's going in the calyx. Only this needle B is hitting exactly where you want to be, but A and C are not going the right way. And this you will know only if you make the C arm rotate for a second plane. And when you see this in an oblique cut, it will tell you, the oblique cut will tell A as going above, so it's wrong, and C as going below, so this is also wrong. Only the B, the middle one, is going towards the tip. So plane A is towards that calyx, and plane B, sorry, the second plane, plane 2, is telling you the depth. Therefore, I feel that it's not a good idea just to do a freehand technique. You have the C arm, it's best to produce the second plane and add to your precision. Now, what can go wrong? Let me show you in this diagrammatic video. If you use just plane 1, when you puncture, you feel you are in the calyx, actually you are behind, and you will give rise to bleeding. Or sometimes you feel that you are in the calyx, actually you are below that, you go through and through the other lower calyx, this is the anterior calyx, this is the posterior calyx, and you create bleeding. And this bleeding sometimes is substantial. It takes the whole flavor away from a nice, clean and neat PCNL. Therefore, the use of 2 planes is very, very important. Now, when you reach the end of what you should know, you will be at the beginning of what you should sense. Some wise man many years ago by the name of Khalil Gibran told us that. So when you do so many things, you feel that you have now known everything. It is actually at that time you sense that you got to know something more. And let me tell you, what is that something more? And that is exactly what I'm going to tell you, that the second plane, how it adds to your precision. So before we come further up with our slides, let me show you on the patient the 2 planes. So this is in the operating room. I'm standing here. The technician moving the C arm is standing here. And so this is the C arm moving towards me first. Okay, this is moving towards me. So this is the triangulation, the bullseye technique. It comes back and it moves towards the foot end of the patient. This is the foot end. That part is the head end. The anesthetist is here. When it moves towards the foot end and you create a second plane, is the triangulation technique. Okay. So you move towards the operating surgeon is plane 2 of the bullseye technique. You move towards the foot end is the plane 2 of the triangulation technique. So let's run the video, actually a short video, to take you through this full steps of puncture. What do we need? We need 4 things. You have to select the site of skin from where you will puncture. You will use 2 planes as we discussed, and we'll come to that. It should be if it's a good idea to do a sonography surveillance. So if you have a sonography unit in the theater, it's always a good idea. And always aim at the tip of the calyx. Don't go by the side. Don't hit the stone directly. Enter through the tip of the calyx. That will be giving you minimum bleeding, and finally fair amount of maneuverability when you enter the pelvic ileal system. Let's begin. How to select the skin site. You put the needle on the patient, don't puncture. So I'm putting the needle on the patient. I'm feeling the spine, one palm and 3 finger breadths away. One palm and 3 finger breadths away is where I will go. That much lateral, I just draw a line. So this is sort of that posterior axillary line. I put the needle once again on the patient. There is no puncture as yet. This is the iliac crest. This is the 12th rib, the 11th rib. And this looks good to me. This alignment looks good to me. It's still on the patient. So I will enter from here. It was hitting the calyx. So my site of entry is here. I create a wheel. This is just for tamponading of the skin because otherwise the skin will keep on bleeding and a little bit of oozing. Sometimes there is a small spurter which keeps on going for 20 minutes. A very small puncture if it's a ultra mini, or a 1 centimeter, 12 millimeter puncture if it's a standard ECNM. So plane one is giving you direction. So once again, these are a bit of repetition. I am here. This is my technician. This is the C-arm. And I put the needle first. I'm putting on the patient. Where does it go? It is going little above the lower calyx. This is where I want to go. But if I go ahead and puncture, this is slightly above. Not a good thing. So I'm not going to puncture in that direction. Let me put it down. I go a bit down caudally. This is too much below. Okay. So I have to be somewhere between these two. So let me put the needle somewhere between this, not here, but somewhere here. And does it hit the tip? Yes, it hits the tip. So this is my direction. Plane one has given me the direction. This is the direction of puncture. I don't know the depth, but I now know the direction. So this is my direction. This is the stone, and I want to hit the tip. I make a small incision. You can use a marker pen or use the blood as ink and draw the line. My direction is drawn. I don't know the depth. Now the depth will be decided by plane two. So this is plane two, which gives the depth to puncture the calyx. And now the C-arm is moved towards the foot end. This is where the foot is. The anesthetist is standing on this side. This is the iliac crest. These are the ribs. I know the direction already, but I don't know the depth. So I make a rough puncture by my experience. I put a rough puncture. Does this look good? No, this is too much deep. This is too much deep. So I have not punctured the kidney as yet. So I pull out and make it superficial. This is the spine prone position. So I'm going superficial. I puncture. I am not puncturing. I go close to the kidney and check. Does this look good? No, it's too much superficial. That was too much deep. This is too much superficial. Once again, I settle for a depth which is in between. I already know the direction, the depth somewhere in between, and that I'm watching. I take the flash in both the position, plane one, plane two. The needle is approaching the same spot in both the position, plane one and plane two. Both the position, the needle is approaching the same spot, and I finally make the push. You can see it's in both the position, it is approaching the same spot, and here you go, you are in it. It's as simple as that. Plane one, plane two, as simple as that. Okay. Once you have done a good puncture, the rest is extremely easy. You just put in a guide wire, a Terumo guide wire 0.035 or a zebra wire or whichever. You know, there are a lot of guide wires, high quality guide wires from the consumable, the disposable manufacturers, and then you start dilating. So this is the puncture. Now let me quickly give you why, for me, triangulation technique is better than bullseye technique. I already showed you this slide that if you want to keep your fingers away from exposure to the X-rays, you will hold the needle with a forceps. That takes away the fine sensation from your hand. When you are puncturing, you with experience, you know you are through the muscles, When you touch the capsule of the kidney, you will know that you are now at the kidney. Then the parenchyma feel is little different. And finally, when you go through the mucosa, there is that popping feeling that here you go into the mucosa. All those fine feelings are lost when you are holding the needle with an instrument which is long enough and trying to keep your hands away. So that is one reason why I am not a proponent of bullseye. And the second reason is that when you do plane 2, you are trying to align the tip of the needle with the tip of the calyx. So you are trying to move the needle, the C-arm is cutting like this, and you are moving the needle and you are aligning the tip with the tip of the calyx. A little difficult proposition. Whereas when you are doing the depth with the triangulation technique, the needle is, the full shaft of the needle is seen. In plane 2 also, in plane 1 also the full shaft is seen, and in plane 2 also the full shaft is seen. This needle is seen totally. So when you want to do a little superficial or a deep movement, when you see the full shaft, you know a little above or a little below. It's ease of mind. It's essentially a 3D picture which you are creating in your brain and trying to transfer it into a kind of a movement which gives you the best effect as a puncture. So that's all what the use of the second plane is all about. Well, there are people who do good punctures even with triangulation technique. So I don't want to argue heavily which one is the best technique. For me, triangulation is better. But for that argument, to put the argument at rest, this is the statement: I fear not the man who has practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times. Bruce Lee. Practice and practice and practice till you are so good at it, you are so confident at it that you just feel that, okay, let me try the other technique also. If I succeed, good. If I don't, you don't feel disheartened. You are so strong with your with the technique which you have mastered, you can quickly finish the job, do justice to the patient, and emerge a winner. So be very, very confident, at least with one technique. And all statements for all the newcomers, failure is essential. If your uniform isn't dirty, you weren't part of the game. And I can assure you, again, to all the newcomers, each one of us, we have, at least I have 12,000 PCNLs under my belt, and there are a lot of experts, people who have written books, but believe me, none of them has the capacity to say that I never made mistakes. They have made horrendous mistakes, tremendous bleeding. So it's part of the learning. But the lesser you make, the better it is. Keep your mentors with you when you are learning, and don't do injustice to your patient. That is very, very important. And also remember, no game was ever worth a rap for a rational man to play, into which no accident, no mishap could possibly find its way. The real challenge is when you play a game which is difficult and yet you master it. There is no fun playing a game which is so easy. There has to be a challenge in life. No, that applies to everybody. And how do you achieve it? Yes, of course, all the slides that told you how to achieve it. But essentially, when you learn from the masters, keep watching them in the operating rooms. And I produced this slide. Essentially, this was for my British colleagues. This is the Prince of England and the Queen, the present Queen, when they were in their early 20s. This guy is looking at her, he's adoring her. And at the end of, I don't know how many, 70 years, he's still adoring her. That is what I call rapt attention. So keep watching your seniors with a lot of attention, what exactly they are doing and how they are good. And very easily you will be able to do the same as the masters of the game. Okay, so that brings us to the third point, selection of the PCNL technique. Now, there used to be a time when there was just one PCNL, standard PCNL, but down the road, last 10 years have brought us newer techniques. The standard technique, which is also called the Maxi PCNL now, the Mini PCNL, we have the Ultra Mini, the miniaturized PCNL, and we have the Micro Perk. So Depending upon the complexity of the stone, you will select the technique, but we'll not go into the details of that, because essentially all these techniques need a good puncture. Whatever you are doing, even if you are doing ultra mini PCNL, that doesn't allow you to do a haphazard puncture. You have to do a precise puncture to get the best outcome and to produce clinical success of that PCNL. So it could be different form of PCNL, but the basis of puncture remains the same. To sum it up, large stones, very big stones, maxi PCNL, stones which are medium to large, most of them can be handled by mini PCNL. This middle size stones, 1.5 until 2.5, is for the miniaturized PCNL. RIRS essentially good results for 1450 millimeters or lesser, and small stones, 8, 9, 10 millimeters is still ESWL. Now that brings us to the fourth and the last point. But as you remember, the second important point, the first was a good puncture, and the second is good armamentariums. You got to have very high quality equipments in terms of good disposables, consumables, and good capital investment equipments, as we call it, the stone breaking devices, because you go in, but then what do? You break the stone so precisely and so quickly without damage to the mucosa and the pelvic calyceal system, and you bring the stone out. So that brings us to a discussion on the armamentarium. Now we all know that we had this game starting in the early 80s, and there has been a lot of, it has evolved a lot. It started with electrohydraulic, good armamentarium, but given up because of its side effects of creating complications. It can create punctures very easily, holes or damage to the pelvic calyceal system. Then came ultrasonic. I started my PCNL in the late 80s, 88, which we had only ultrasonic intracorporeal device. Then in the early 90s, this pneumatic device comes up. I saw it for the first time in Sevilla in the SIU meeting. I was a young man just out of my residency, a junior urologist, and I got a small talk. Perez Castro invited me to Sevilla, and there in the booth, there was a device, pneumatic lithotripter, a company called EMS, and there a tall young man was standing there, which later on I came to know that his name was Mr. Boona. And I asked him, do you have this equipment in India? And he said, no, only in Europe, which left me disappointed, because I saw that that was a nice device. So that was my first impression about the lithoclast, the standard lithoclast, which came in the early 90s. Both Mr. Booner and me were young then. Both of us are not now, but nevertheless, it's always a pleasure seeing him. Lately, just about 2.5, 3 years back, I could see him in Neo. Anyway, and finally, the combination came up. We realized the value of ultrasound with pneumatic. And once again, EMS comes up with a combination that use ultrasound if you like, use pneumatic if you like, because ultrasound had an inherent advantage of adding suction to it. You break, and at the same time, you pull out the fragments, which pneumatic could not. But pneumatic was a stronger energy. It could break very hard stones and faster. So you could take advantage of either one in the form of a lithoclast master. And then, of course, miniaturized PCNLs came in, flexiureteroscopy came in, where you had to put in instruments, or rather the breaking devices, which would go through those flexible routes, and that was laser. The laser fiber is the only energy which goes through a flexible instrument. The powerful energy is ultrasound or pneumatic. The mechanical will not go through the flexible route. So let's one by one discuss all this. So essentially, the non-laser form of technologies were electrohydraulic, ultrasonic, and ballistic. Electrohydraulic given up, ultrasonic and ballistic very much here to stand. I already told you it started off with ultrasonic. Ballistic is added later on, and and then comes the combination. So the combination is the coarse fragments comes with ballistic, fast, but a little flying away of fragments is possible. And the fine fragments comes with ultrasonic. So then comes from the lithoclast, there is lithoclast master, which is this device. A little bit of a disadvantage, which down the road we all realized, was that the pneumatic probe was going through the ultrasonic probe, so it was occupying space. So when you had both in position, when you used the ultrasonic, fragments, larger ones could not be sucked out because the ballistic one was occupying space within the ultrasound. And constant innovation, constant thinking, constant interaction with the endourologist and the EMS team, the research and development team, and team on the ground, bringing information from different parts of the world that this is what is required. So there we end up getting one more state-of-the-art unit, and that we all know is the Trilogy, which I will come to it later on. So the first device, the standard lithoclast, then the lithoclast master, and finally just a couple of years back, this was launched in the WC Paris, the Trilogy equipment. We have it in our operating room, a wonderful device which has, in a single probe, the mechanical, the ballistic, the ultrasonic, and the suction. And therefore, they appropriately named is Trilogy, 3 things in a single probe. So let me run through this small video of Trilogy. So this is the unit, a sleek unit, not very heavy, easy to move in the operating room. This is the hand probe, looks a little bulky, but very balanced. When you hold it and when you're operating, even in Ultra Mini, I've never felt that I'm holding something very heavy and I'm a bit uncomfortable. So this is a patient, very obese, BMI 38. We did this in a prone position. So this is the hand piece. As I said, it looks like a gun, and a standard puncture, a standard track. The stone is very hard. I already showed you a very hard stone, very high HU, more than 1400. The first thing is a little bit of clots. You suck it out very quickly in 30 seconds. So the image comes very neat and clean. You have the option of choosing the intensity of each energy. Your ultrasound could be 70, 80, 100, whatever you want. Similarly, that the shock energy, the ballistic could be whatever, 60, 80, 100. You can have a combination. And look at this stone. This is a real-time video I'm showing you. It's edited by taking away a bit of the procedure, but otherwise it's a real-time video, and I'll show you the timing. A big staghorn stone, I'm just eating it away. You can see how it punches a hole. Ultrasound and pneumatic both are activated. Ultrasound is roughly 70% and pneumatic is close to 90%. After 6 minutes, almost 40% of the stone is gone. The other beauty is there is no flying off fragments. It's sucked away. The field remains neat and clean. Even if there is a little bit of bleeding, suppose the puncture is not very good, the suction is continuously taking away that fluid, and the new one which is instilled gives you a good vision. Look at the vision. At the end of 12 minutes, a lot more stone is eaten away. And as you progress further, there is a lot of, you can see there was friable mucosa. The stone was there for a long time. There was friable mucosa, but if you don't touch that mucosa, inadvertently, if you touch it a little, nothing happens. If you keep on touching it, there is a little bit of oozing which happens. So equipment in 18 minutes took away a staghorn stone. So we have used this in standard PCNL, in mini PCNL, and we are also using it now in the ultra mini PCNL. And the combination ultrasound with pneumatic is delivering good results. You can see that this is the stone pulled out in 18 minutes. Look at the amount of stone pulled out in just 18 minutes. And finally, we cannot finish everything with this pneumatic or ultrasonic devices. We got to have laser. I told you why, because we need to put it through flexible routes also in Flexi URS and in the miniaturized PCNL. So we have this very sleek toy which produces excellent short pulses as well as long pulses. We can play with that depending on what you want. The short one is for quicker, faster delivery of energy, and the long one is to keep the stone not flying away, more for dusting. So you can adjust that, the frequency and energy. But by and large, for a mini PCNL, you never need energy beyond 1.2, max 1.4, and a frequency of roughly 10. This can produce much more, but I have never tested the upper limits because most of the stones, we are producing small fragments in miniaturized PCNL, and that can be achieved by this setting of a 10 frequency and a 1.2 energy. You can always bring it down to 5 hertz. You can increase the frequency, and bring the energy to 0.5 or even lesser if you want to go for pure dusting. So we already know the advantages, disadvantages of short pulse, long pulse. Short pulse is, as I said, for producing more energy, quicker, faster. Long pulse is for dusting, keeping the stone not flying away. So this is how you play with the energy and the settings. So in short, now the large stones is trilogy. The miniaturized stones, miniaturized versions of PCNL is the laser. So which we use, we have this laser class in the operating room where we'll use that for miniaturized and trilogy for the standard and mini PCNLs. Finally, remember that when you do all this, when you use all these equipments, you come to finally a conclusion that trained urologists change themselves according to the situation, but experienced urologists can change the situation according to them. You can very easily play with all these gadgets, and you can always tread on this defining zones. You can always overlap because of your training and your expertise. And I have to tell you at this juncture that there are a lot of people wanting to learn, and there are pamphlets and videos being distributed, but people, they always say that, well, still I need something more, and that something more to a great extent has been provided by these EMS master classes, where the mind of Jerome and Uli are applied. Uli moves around the world to produce these master classes, because the young guys ask, if I don't learn the way you teach by giving me videos. But if I don't learn the way you teach, then teach the way I learn. I learn by actually going into the operating room and seeing the procedure and sometimes getting a feel of the procedure. That is how I'm going to learn. And these master classes are providing that from the last several years. And we have done now almost master classes in Ahmedabad on a very regular basis. We'll be doing one in November. And of course, you can get in contact with Uli and Domenico, who will be in charge of this part of the world, to register yourself. And I hope by this time, November end, the world is pretty stabilized from this effect of COVID-19, and we'll be able to hold the masterclass. But you are all welcome to come there. We are waiting for this corona prevention flights. And the other day I told Katya that this is the new hairstyle, corona hairstyle. You know, the virus does not go into you. So the girls, the boys can't do that. And finally, before we raise a toast, this is the way to raise a toast until we meet. This is the only way to feel happy and maintain cheer in this atmosphere of difficulty and a little bit of gloom that corona has brought up. So cheers, friends all around the world. And thank you once again to everybody. merci, obrigado, gracias, mulțumesc, sheshe, shukran. All this, the movements around the world has taught me at least saying thank you in different languages. So Efcharistos to the Greek guys. So bye-bye for the time being, but I'm very much here to take your questions. Thank you.
Yes, thank you so much, Janak, for this very interesting presentation. We have a few questions which I can read and introduce to you and forward to you. There was one from a participant. He was asking, why not use both oblique views and if oblique views is C-arm do a perfect puncture?
I didn't get the question actually.
So actually there was the question, why not use both oblique views in C-arm to do a perfect puncture?
What he means, both means the triangulation as well as the bullseye. I assume the question means that, both the oblique views. Is that the question?
Yeah, actually, I think it was the question. He was not, why not use both oblique views in C, if the C-arm is
you can, yes,
puncture.
You can,
yeah.
You can actually, you can use both the views, but the reason I'm not using the bullseye technique is when you use the bullseye technique, my hands keep taking the brunt of the radiation. That's the main reason I don't do. And the second is the oblique cut is best obtained by almost a 45 degrees tilt, 90 and 45. When you do this bullseye, you bring it towards you. And when you want to do a little more movement, you have to go away. As the C-arm comes towards you, you are pushed away. Then only you get a little additional, more than 30 up till 40. So the real value of the oblique is you are close to 40 or above. If you are lesser than say 25, you are very close to plane 1, and that really does not give you the depth. So keep that in mind, that you've got to produce a real oblique view. If you are lesser than 30, you sometimes will end up making a mistake. You are not guided for the proper depth. I hope I made myself clear.
Yeah. Thanks for this answer. There was one more question from Leonardo Lopez. He asked, in complex cases with multiple calyx with stones, what is your choice? Use SEERS, so endoscopic combined intrarenal surgery with flexible, or make additional tracts with mini PCNL or ultra mini perc. So question whether the combination or multiple PCNL tract.
Okay. I have no hesitation in saying that this combined approach, the ECIRS as we call it, has a definite value. There is a definite value to it. But if you see we do a lot of stones and we rarely need that ECIRS. We rarely need it. You go in with a good puncture and you will be able to take a major bulk of the stone out of the system. And then if it is in a calyx which is not amenable to reaching easily, you cannot reach that part of the calyx and that stone remains away from your vision, you have the option of putting in a flexible scope through the puncture itself. You have the flexible scope going through the puncture into that calyx. You don't have to engage another surgeon doing a flexi ureteroscopy and going in from below. You can yourself use a flexi instruments and go to that calyx. Now, when do you really need an ECIRS? Is when the angle is so acute that if you have gone through the lower calyx and you have to bend it so much that the calyx just above the lower one has one fragment remaining where you can't go in actually, then you have to go in from below and reach that stone. So that is the only indication of a combined approach, in my opinion. Okay.
Okay.
And you can, if you feel that there is a small fragment, and if you already are a stone center, if you have a lithotripter at your disposal, many a times what we do is, instead of becoming very aggressive, we tell the patient that after 2 months, one sitting of lithotripsy, that will take away that fragment which was 8 or 9 millimeters. Sometimes we do that also.
Okay, next question. So we have many questions here. I go question by question through all these questions, as we still have time to answer all these questions. Next question was, have you observed any damage to the wall of the renal mucosa due to the impact energy of trilogy during your experience? One of the doctors had raised this issue when he used trilogy.
Okay. The short answer is no. So far,
okay.
No. But if you see any energy, any device, if you make a mistake, if you don't respect the standard protocols, you will damage. But otherwise, it's a safe energy. Inadvertently, by mistake, if you are doing it and a little bit touches, which electrohydraulic created problems in those days, even a little bit and boom, there will be a rent in the mucosa, in the wall. This will definitely not do it.
Okay, next question. What about lateral position? What is your opinion here?
You mean position for PCNL?
I think
yeah,
probably it was that yeah.
Maybe what he means is, there is one which is absolute prone, there is absolute supine, and there is this modified supine position. So it's actually the modified supine is the best way to go. A little tilt is what would be better. That would be better.
Okay.
So and Guido, he's a master on that. He's going to engage you on this after a week.
That's what we will talk about next week about. Yes. Have you observed any damage of the walls of the renal mucosa that was a question we already answered. How often you resort to supracostal upper pole puncture in your practice?
Yes. So depending on the lie of the kidney, some kidney are high up. You can see that more than half the kidney is above the 12th ray, more than half. Some kidneys are very low down. Some of them are so low that they are very close to the iliac crest. So it all depends on how the nature has positioned the kidney for that patient. So depending on that, in short, if the stone is quite high up, and if you puncture for the lower calyx, it is technically a challenge to maneuver your instrument and go up till that stone. There is a lot of torquing that will happen. Don't do that puncture. It's best to go through the upper calyx between the 12th and the 11th ray. Between the 12th and the 11th, fairly safe. You may touch the pleura, but you will not damage the lung. So a little bit of brushing of the pleura is not going to be a big problem. And try and puncture always in inspiration. In inspiration, the kidney goes down. Okay? So don't puncture in expiration. When the patient tell the anesthetist, push, bring the kidney down. It is at that point that you will puncture. Pleura is a fixed organ. The pleura is attached to the ribs and the different parts of the body. It remains as it is. It is the lung which moves inside a little bit up and down. So in inspiration, the pleura is not going to move up and down. The lung will definitely move down, but at the same time, the kidney moves down. And that is the time you puncture. You get my point, why I'm telling why puncture in inspiration? So do that.
Okay. One more. What is the difference? Is prone PCNL, is it by default? Is it the posterior calyx? Is it a need to be, or let me repeat the question. In prone PCNL, is it by default? It is posterior calyx. It needs to be, not sure what he or she means.
So I can sense the question. I may be wrong, but I can sense the question that in prone position, by default, it is the posterior calyx that comes towards you. You are right. Yes, the posterior calyx comes towards you, but sometimes the posterior calyx is shorter and the anterior is longer, and you feel that it is the longer one is actually the posterior calyx. You may end up making a mistake. And the natural fallout of this question is, then how do you know that this is anterior or posterior? Mm-hmm. Point number one, by that 3D CT scan, which you already got it done pre-op, and you know that this is the actual anatomy. So always ask for this 3D rotational images. Number two, by and large, not always, but by and large, the posterior calyces are longer than the anterior calyces. Number three, some people, they push in a little bit of air in it. Air is lighter, and a little contrast, not full contrast, with air, and air will occupy the posterior calyx being lighter, and the contrast will go in the anterior calyx, which is lower down by gravity, and therefore you differentiate that this is anterior or this is posterior. And still at the end, with all this knowledge, you will still go wrong in roughly 5% cases. Don't worry.
Okay, I hope this answered the question. Next one, how much do you move laterally after you put the needle at the tip of the calyx before you use bullseye, or before you bullseye or move the C-arm? You got it? So again, how much do you move laterally after you put the needle at the tip of the calyx before you bullseye?
Yeah, so that's another way of saying how much tilt you have to make. But I just wanted to add to the last answer, and this anterior posterior can also be distinguished or differentiated by sonography. If you are a master on sonography, the moment you slide your sonography probe more laterally from back, more laterally, you will know that this is the posterior calyx, and now as you slide it further, now you have hit the anterior calyx. So a mastery on sonography also helps you do that. Now this question, how much laterally you move the C-arm so that you know how to hit the tip of the calyx? I think I answered that. 30 degrees is minimum. You know, I would feel I'm comfortable only when I'm 35, 40. Anything less than 35 is not a real oblique cut. And that in some difficult situations, you are still a little above or below the calyx, and that will not enable you to puncture on a single pass. You will struggle a little bit. So a little closer to 40 would be good.
Okay, do you use a drain tube after PCNL?
The standard principle is in miniaturized PCNL, most of the times no, 85% of the times no, but if there is a trickle of blood coming along, even at the end of 5 minutes of waiting, a feeding tube in miniaturized PCNL. In mini and standard PCNL, well, again, it depends on if it's a neat, clean PCNL, there is very minimal bleeding, and you can make it a tubeless PCNL. You can definitely make it a tubeless PCNL. But somehow psychologically, I'm inclined to put the tube for at least 12 hours. It takes away the clots, the blood, if at all. It gives me the ability to go in again if it is required the next day or the third day, if at all. So maybe 1 day of tube is not a bad idea.
Okay. There is one question coming from Nepal, from Dr. Shuman Sharma. He was asking, what is the best puncture technique in horseshoe kidney? Any recommendation?
Yeah. So Suman, in horseshoe kidneys are the best to puncture, the easiest. Why? Because the horseshoe kidneys are always lying low. They are not yet in the process of the kidney going up when the baby is is being produced. They have that upward migration is arrested and they get joined. We all know this. So even the upper calyx puncture is below the 12th rib. So horseshoe is the best puncture, I tell you. The only flip side is there can be a little bit of aberrant vasculature and that you have to be careful. You might encounter a little bit of aberrant vasculature, but that's more towards the medial part, towards the hilum, and you are puncturing the upper pole. So horseshoe kidney, by and large, is an upper calyx puncture. By and large, below the 12th rib, you go in and you go straight down and you can see the lower calyx. The horseshoe kidney is actually an easy puncture.
Okay. One more question about puncturing. Can we puncture above the 11th ribs, and is it safe?
Can you puncture above the 11th rib? Yes, you can. Is it safe? 25% chance that you will create a hemothorax or fluid collection in the pneumoperitoneum. So remember that. By and large, try and remain between the 11th and 12th. Between the 10th and 11th, you can avoid doing that. Even if the stone is very high, you can actually bring the kidney down. Have two ways. One, you can puncture the lower pole, which is of course below the 12th rib, and you can put in the guide wire, the first 6 French Teflon dilator, and the guide rod, and with that you can bring the kidney down. You can actually use that as a fulcrum, and you can bring the kidney down by at least 2 centimeters. So what could have otherwise been a puncture between the 11th and the 10th now becomes a puncture between the 11th and the 12th. So one point of bringing the kidney down, that is one part. The second way of bringing the kidney down is those ureteric catheters with a small balloon. The balloon ureteric catheters, little more expensive than the standard ureteric catheters, but you bring that ureteric catheter up to the UPJ, inflate the balloon by 3 cc, so the balloon gets engaged at the UPJ, and pull the ureteric catheter a little gradually. You will see that you are bringing the kidney or pulling the kidney down by that traction. So the same thing, you have actually brought the kidney down and made yourself safer. So this is how you can approach.
Mm-hmm. Good, thank you. For the moment, the last question is, what is the incidence of infective complication in your practice? Does using suction along with lithotripsy reduce the incidence of infective complications?
Yes. So 2 parts to the answer. Definitely PCNL can lead to infection. So pre-op, when you prepare the patient for PCNL, you get the urine test done. If there is infection, get a culture done. Appropriate antibiotics should be started. Try and make the system sterile, which you may not achieve all the time because the stone itself is obstructing and not allowing the system to become sterile. But try that under the coverage of antibiotic. And the second part, yes, if the pressures rise, there will be bacteria which can go through the lymphatics into the system and can cause infection, sometimes even septicemia. And that is one of the arguments which goes in against the flexiureteroscopy, where the pressures rise more than PCNL. In PCNL, the inflow and the outflow is always balanced. The outflow track or channel is so good that what goes inside comes out very easily. That's always, and therefore, if you have done PCNL the proper way in a sterile situation, which you have obtained beforehand, the chances of creating infection actually are very, very minimal.
Okay, there's more. We have more questions, still more questions. One is regarding your way for dilation. Do you prefer more balloon or the so-called old way with alkane dilators?
Yeah. So this debate goes on and on. In short, I use the alkane dilators. Why? Number one, cheaper. These alkane dilators can be sterilized a number of times. I have 2 sets, and which has enabled me to do, believe me, more than 12,000 PCNLs. One. If people who don't believe in saving money, or that's bullshit, we don't mind spending money, even then I'll use the alkane. Why? Because when you do a balloon dilation, you are pre-deciding that I'm going to make a track of 30 French and therefore open a balloon of 30 French, or you are pre-deciding that I'm going to do 28 French. So open that balloon accordingly. When I do an alkane dilation, I start with the set one by one, and I feel that this stone, or this is I'm going between the ribs, and the ribs are too tight to allow more dilation. Let me stop at 24. I don't use the last two and stop at 24 and put my implants, and still I'm good enough. So I have the flexibility. As I proceed, during the procedure, I have the flexibility of deciding how much I want to dilate. That's not going to happen with the balloon. Okay. And the second point with the balloon is, if the fascia of Gerota, when you are operating in a system which is already operated earlier, and there is a lot of fibrosis, sometimes there is what is typically called a waist in the balloon. The central part of the balloon doesn't open up. You apply pressure and still it does not open up. And when you want to pass your implants over it, it is there you are struggling. The implants does not slide below the second part, below the waist, beyond the waist. Sometimes this happens, not always. So that is again a little bit working against the balloon for me. And finally, a little complicated, but listen carefully. When you are dilating, what happens with a balloon? You've put in the needle, you've done your initial implants up till 14, and now the balloon goes in and pop, you want to dilate. So the balloon applies pressure radially in all direction. Radially, it applies pressure, and there is a possibility that sudden 30 French dilation, there is only a radial pressure applied to the parenchyma, and one weak spot of the parenchyma may give way, and there can be a little lateral tear, a little bit of a lateral tear. The possibility of this happening in alkane is slightly less. Why? I'll explain. When you put the alkane dilators, 16, and then over that goes the next one, you are dilating and you are rotating. So you are pushing as well as you are rotating. Two things are happening. The rotation applies the lateral dilation. What is this becomes this, becomes this, becomes this. Okay, that's the dilation. But when you push the dilator and also twist it, you are pushing gradually and twisting it. So the dilator is progressing and making way inside and distributing that radial pressure in such a way that suddenly a pop on the weakest part is not happening. You are distributing it. It comes a little bit to the weak part, but immediately goes to the strong part as well, and you are progressing further. This is a very fine difference between a sudden pop and distributing the lateral radial energy. Therefore, I like the alkane dilation. And finally, people would agree or argue that you save time. A lot of people have seen me doing this. I can bet and tell you, it never, if your puncture is good, after the Teflon dilator, if you start counting steadily, 1, 2, 3, 4, I can guarantee and tell you will never go beyond 20. Before that, my dilation is over with alkane.
This was what I can confirm. That's pretty much right. What you say.
Uli has come to a level where he can do this talk without me, and he can do the operation without me.
So, Janak, we have one more question for you. What about the renal displacement maneuver, moving the kidney down through the initial puncture and to access the upper pole?
Yeah, I think we discussed this already. There are 2 or 3 ways in which you can do that. You move the kidney, and so I would very strongly recommend don't puncture between the 11th and the 10th rib.
Okay.
If you have to, you can always convert that into a puncture between the 12th and the 11th by bringing the kidney down.
For the moment, that's the last question I see here in our question and answer files. I just read it. Sometimes when I puncture the kidney, it's drained out. Is it important to abort the operation, or can we give extra antibiotics and continue the PCNL?
Okay, so depends again on whether the patient is diabetic, he has comorbidities. When you did the preoperative culture, was the organism Pseudomonas or Proteus, or it was just E. coli, so difficult versus a little less difficult organism. Sometimes you see pus, but actually it is sterile already. So depends on all these parameters. If you do that, and if you put the trilogy, you suck it out, which is one more advantage of the suction mechanism incorporated. You see the stone well, and you feel that you will finish the whole game very quickly in 10-15 minutes, and you have a definite large channel for the outflow. You will not raise the intrarenal pressure. Go ahead and finish the PCNL. If you have a doubt, drain the kidney first. That will depend on how sick the patient was. Right? If the patient is not sick and fairly okay, finish the procedure. If the patient had that problem, drain, allow the patient to recover, allow the count to settle down, control the diabetes, and then do the actual procedure after 3, 4, 5 days.
Okay. One more. Does continuous suction used along with ultrasound energy in Lithoplast Master or Trilogy can result in the occurrence of increased bleeding due to the negative pressure we produce?
Yeah.
Yeah.
Okay. In a way, that's a good question. That you keep sucking, so more blood keeps coming. Well, don't apply too much of a suction. Anyway, assume that you are not sucking. The bleeding is going to continue because there is an outflow already. What is going in is coming out from the outflow channel, and the bleeding is going to continue. But if you add suction, which is very heavy, you are pulling out, so more blood is pouring in. Now, this scenario is going to happen when the puncture is bad. If you really feel that the moment you decrease the level of suction, there is all red inside, that's a bad puncture. You are unlucky. That's an unlucky day for you. So either you quickly finish it off, or if you feel no, it's a real bad bleeding, best to put a nephrostomy, let it settle, go in again after 4 or 5 days. No matter who you are, no matter you are X, Y, Z, with an experience of 3, 4, 10, 20,000 PCNLs, never make it a prestige issue. The patient safety comes first. Remember.
Good. One more question regarding PCNL. Can PCNL be done without functional anatomic assessment?
Well, when you say functional assessment, you mean you have not done a renal scan. That is the actual functional assessment. You do a renal scan and find out the differential function, that this kidney is whatever, 40% and 60 or whatever. The differential function, as we call it. That is the real functional assessment. The other indirect functional assessment is you have done intravenous pyelogram or CT-IVU, and that is already giving you an indirect assessment. The contrast goes down, there is no obstruction, and that is good enough, because when the contrast comes in the pelvic calyceal system and is washed out, that kidney has to have a good function. So without the CT IVU, I will never ever do a PCNL. But renal isotopes can always, no, not really. With the CT IVU, you can definitely take your call and go ahead.
Yeah. There's one question you have maybe already answered, but I just repeat it again. There's a question, what is the best start for beginners in prone or supine position? What is your opinion?
Well, you come to me, you will embrace prone to begin with. You go to Guido, you will embrace supine to begin with. But then having done that, exchange again and go to both and learn both. So that's the answer. Well, more part of the world right now, the whole of America by and large is doing prone. The younger generation is embracing supine one by one. A lot of India is doing prone, but supine is getting picked up. So I think the statistics as of now are more in favor of prone than supine, but both will give you good results. You just do the job well.
Okay, there was one more question regarding bleeding as well. Can we use, I think it's anticoagulation electrode through the nephroscope if the bleeding is visible?
Yeah. Yes. So what he means is, if there is bleeding, can you coagulate it?
Yeah.
The practically speaking answer is no. What needs to be coagulated will never be achieved by coagulation, and what can be coagulated does not need to be coagulated. You get the point. The bleeding that you can coagulate actually will anyway it's going to stop on its own. You don't need to coagulate. And what needs to be coagulated, you will never achieve by coagulation. It will, the more you apply, the more it will bleed. So the best is call it a day, quickly put in a nephrostomy tube, apply a clamp, hold on, it will stop. The nature is therefore, it's very difficult to differentiate between good PCNL, good experts, and an average one and the bad ones, unless you watch them again and again. But the patient will not be able to differentiate much because of the benevolence of nature. There are two kidneys, first of all. If you messed around with one, still the patient goes home. Okay? And at the end, it's such a benevolent organ that it will bless you and it will easily put a cover on your mistake of bleeding. The bleeding eventually stops.
Okay, for the moment, this is the last question that appears on my screen. I think it's more a statement, probably. You do CT urography in all cases, as many people are doing PCNL, with non-contrast CT? Question mark? Yeah.
So if the creatinine is okay, we do a contrast CT. It is, I think, the question which normally, having done so many workshops, these are the normal questions on this topic, that do you need a CT? Can you not just do a regular IVU? Do you need a CT IVU, or just a regular IVU is good enough? Regular IVU is good enough, but if given a preference, I will do a CT IVU. And now with CT scan in all hospitals, even in small clinics in small cities, it's not difficult to access a place which will give you a CT IVU. So I think the standard of care now is ask for a CT IVU. It gives you the Hounsfield unit. It gives you the anatomy a little better. It gives you, with the 3D image, the possibility of knowing what is anterior calyx and posterior calyx. So try and get a CT IVU. That's the call. Now, whether that CT IVU is a contrast CT IVU or a non-contrast CT IVU will depend on the creatinine. If the creatinine is high already, obviously it will be a non-contrast CT. You can't push in contrast with the creatinine which is high. So so the radiologist will always ask for a creatinine report. So when we write a note to the radiologist, we always attach the latest creatinine report and tell them that it's normal. So please do a contrast CT IVU or otherwise.
Yeah. One more question regarding PCNL. How often can we do a PCNL on the same kidney? So means the number of PCNS can be, how often can we do it?
Yeah.
One,
So
repeat.
the answer is yes. The senior people, like people who began PCNL in the 80s, will be able to tell you that they did PCNL, and then the same patient came again with a second stone after 10 years, and the same patient came again with another stone. So we have done PCNL 3-4 times on the same patient, which I have done. You can do that. And the second way of answering, which is a little tangential way, is on the same kidney, how many punctures you can do. When we began, we used to feel very macho when we used to do 6 punctures, 7 punctures. Look at my skills of PCNL, 1, 2, 3, 4, 5, and all the nephrostomy tubes dangling away. Well, as you age, you become sober, and when you show that, the risk taken actually is by the patient, not by you. You are a rather over-aggressive surgeon. That's the feeling you get once you mature as a surgeon. So now I feel 2 punctures, good enough. There is no need to be very aggressive. With all these good devices, you will be able to eat away a lot of stone. The second puncture, where the stone is very big, can allow you to take away almost, with these 2 punctures, more than 90-95% of the stones. And then a little bit of flexi here and there can bring you close to 100%. There is no need to be very aggressive and add a lot of punctures.
I think the question was more, doing a PCNL with several punctures, only 1 puncture. But if the patient comes back after a few years, how often can you repeat this procedure in 1 kidney on 1 patient?
I have done the 4th time also, as I said. Done the 4th time also. So this is
just there any limit where we would say, okay, he underwent 5 PCNLs so far in his life. This is now too risky to have a huge damage on this kidney, and we cannot do it anymore. Let's do it in the flexible way.
No, I don't think so. I don't think so, because the puncture that you do, there are studies that you do the puncture and you the dilation. If everything has gone well, you are damaging between 3 to 5% of the nephrons, roughly. Okay, yeah. So each puncture you are minus, say, 5% of the nephrons. So you are going for the 4th time, then 5 into 4 is 20% of the nephrons gone, and still you have a reasonable, more than reasonable amount of kidney functioning for you. Good. That is one part. And the second part is, if you are hitting the lower pole, if you divide the number of, the site of punctures, the lower pole comes to close to 40-45% in PCNL. Then the middle and upper is the least. So when you are doing a lower pole puncture, and after 4 years again you are doing a lower pole puncture, and after 10 years again you are doing a lower pole puncture, by and large you are going through the same spot and then not actually adding 5%, but that fibrotic zone is again being punctured for the second time, and that more or less the same zone is again being punctured. So I think PCNL can be repeated 3, 4, 5, 6 times.
Oh, okay.
No harm.
This does answer the question. So far, one more. I think then we are really coming to an end. This question is in regards to anesthesia. What about eye spinal anesthesia?
Okay. Spinal anesthesia is a little inferior from 2 angles. One is that the patient is in a prone position and he is relatively awake, and to lie steady for 1 hour, 1 hour 15 minutes, not an easy job. Sometimes apprehension hits the patient, sometimes being too steady, without movement, not a good idea for the patient. And the third thing is He is obviously going to breathe and sometimes a little deep breath, and the kidney suddenly moves because of the breathing. When you want to puncture, you want to keep the kidney steady as possible. If it is a general anesthesia, you tell the anesthetist, hold on, give me 30 seconds of an apnea, no breathing, and I will do a puncture, then again start the breathing. All this is not possible in spinal. So it is possible. I mean, it is better you do it under general anesthesia, but I've done PCNL in spinal several times. Also, you want to save money. For example, in the developing world, spinal is cheaper than general anesthesia. You want the patient recover faster, quickly go to the go out of the operating room and you are absolutely conscious. The patients are a little apprehensive about general anesthesia, some of them. You can do it in spinal. Better is general.
One more. Can we do PCNL with plain CT, even in a patient with normal creatinine?
You can, but the contrast gives you the answer to that previous question, the function, right? Indirectly, it is telling you that the function of the kidney, both of them, is good enough. So that is number one. And the ureter, the anatomy of the ureter is always better understood with the contrast. Without the contrast, the ureter, you are taking multiple cuts as you go down, and the whole ureter is difficult to be seen in a non-contrast CT. It is easier to be seen in a CT with contrast. So these two reasons mainly.
Okay. I think, yeah, we are coming to the end. There is no more. Yeah, there's one more. It just popped up. What is your take on epidural anesthesia? That's the doctor, I think it's Milind Parikh, I think he is from India. I have a very good experience of more than 2,000 cases with epidural anesthesia.
Yeah, Milind, so epidural, yes. Post-operatively, no pain. So the whole procedure is very, very patient friendly. Even if you put a nephrostomy, that is actually the reason of pain. That the tract contributing to pain is very less. It is actually the nephrostomy which contributes to pain. So with an epidural, you top it up and the patient in the next 24, 48 hours is pain-free. So that's one part of it. But giving epidural is a little more time consuming. The anesthetist has to really work a little extra to produce that epidural anesthesia. So if you can do that, no harm, absolutely okay. There is a little benefit attached to it. But to add on to this question, there are some people who give a little bit of infiltration of local anesthesia paraspinal. They feel the lateral process of the vertebrae, and just between the two, they inject with a long needle local anesthesia. So the nerve coming out from the foramina are anesthetized at that very spot, and that remains a long-term anesthesia is given, that long-acting anesthesia, and the patient remains pain-free for a longer time on that day. I saw this very nicely being done by Dr. Serrano from Bogota. He has a huge experience, a very low-profile gentleman, a very nice urologist, speaks less but knows more, and he does this. Infiltration. So there are ways of making the patient pain-free for a longer time, and in which epidural can play a role, definitely.
Yeah, one more. I think this will be the last question, as we have to finish this session right now. I will just show my email address and the Twitter account of EMS, where you can ask more questions to Dr. Desai, I will forward this later on to you. Last question for today is, I think we touched it a little bit already. What about your opinion about plastic dilators compared to the metallic one from Mr. Alken you are using regularly?
Yeah. So you mean those blue plastic dilators, the set?
Correct, probably, yeah, that's what he meant, yeah.
Okay. Okay. So the plastic dilators, when you put in, for example, number 18 and you pull it out to be exchanged by 20 or 22, until the time that you pull and then reintroduce the next one, the tamponading is gone. The bleeding continues. In Alken, you put the dilator and it remains there, and then you put the next one which fits into it, and the next one that fits into it. So the tamponading remains. The bleeding is controlled all the time. You are just adding the dilation. You are not taking the full thing away and putting the next one in. That is the main difference. That is the main difference between those blue or those Amplats dilators, as we would call them, and the Alken dilator.
Okay. I know I already said this was the last question, but there's one remaining. I think then we will close this session because I think it's an interesting one. Question is, can we perform a PCNL through a nephrostomy tube done by a radiologist for an emergency reason?
Yeah, of course, of course. This is how say in UK or a lot of Western world, the radiologists started doing the punctures, and even today it's the team that do the puncture is done by the radiologist, and subsequently the PCNL by the urologist. The nephrostomy were put in emergency on weekends where the urologists were not willing to struggle or strain themselves to run and do the emergency nephrostomy. So that forte, that part of the skill went to the radiologist, and it has continued thereafter. But it's a good teamwork. I have been in those parts of the world where the radiologists do the punctures, and it's a very nice team. Ollie Wiseman has Andy and Darren Smith in UCLH. He does his radiologist will do the puncture. So anyway, so you can go through the same track. In fact, it is easier to go through that same track. Yes.
Okay, Janak, then thank you so much for all these answers. I think we had some very interesting questions. I think.
But let me, I'm interrupting. Sorry.
Yeah, please.
The last question. Sometimes the radiologist, when he or she has done a puncture in an emergency, he or she is just trying to drain the kidney. There is infection and trying to drain the kidney, and the puncture is sonography guided and may not be very accurate. As we said, not going through that typical tip of the calyx. It could be just enough to drain and tide over the crisis, and the puncture is gone actually between the tip of the two calyces, and good enough to tide over the crisis, but not good enough to then expand that dilation and finish the PCNL. So before you proceed with the dilation, put a contrast, make sure that is a good puncture. If you feel it's a compromised puncture, avoid that and make a new puncture. Sorry. So go ahead.
No, that's fine. Explanation from the expert is rather better than repeating questions again and again. Okay, I think there are no more questions. I will share the screen again with my email address. You can send me a WhatsApp or even raise your question on Twitter. I just show you the screen, and on the screen my email address for a few seconds. For those, we still have 120 participants online. So this should be enough for those who would like to note my email address or send me a WhatsApp. And yeah, thanks a lot again for spending the time with all of us. I think it was a very interesting session. Even the number of questions indicates this. So there's a lot of things to learn, but I think PCNL is not, as many people say, it's an obsolete procedure. No, it's getting more and more important, especially when we are miniaturizing this procedure as you do in India. So it still has his place in the endourology and the stone management.
Absolutely. Absolutely.
Yeah, absolutely. So yeah, thank you very much again. And I hope everyone enjoyed this first EMS urology webinar, and hope to see you again on this channel next week with Dr. Guido Giusti. Thank you again, Janak, for your time.
Thank you so much. Thank you.
Bye-bye. Bye-bye, everyone.